Good afternoon. I'm going to be talking about preoperative evaluation and perioperative management of patients with ALS today. This is just a small window into the perspective of the anesthesiologist as we care for these patients. At the end of this presentation, my goal is that you have a better understanding of what expectations ALS patients should have about anesthesia and the goals of anesthetic care, especially in these patients. ALS patients often require procedures that help improve their quality of life, the most common one being a G-tube placement. Other procedures include tracheostomy placement, MRIs, placement of phrenic nerve stimulators, and surgical management of pressure ulcers. During the preoperative evaluation, we assess the various symptoms of ALS, all of which present a challenge during anesthesia. The extent of respiratory compromise is assessed by reviewing the most recent ABGs and PFTs. That helps us understand better the patient's pulmonary reserve. The use of non-invasive positive pressure ventilation is also assessed such that the patient who may use their PAP during the day versus during the night or around the clock, that guides our management of ventilation during the procedures. Control of oral secretions is also important. As you can imagine, this increases the risk for aspiration, but also affects the adequacy of oxygenation and ventilation. The extent of bulbar involvement is also evaluated during the preoperative evaluation, since coughing, swallowing, and maintaining a patent airway is affected in these patients. Patients with ALS can also have autonomic dysfunction. This leads to marked swings in blood pressure and hemodynamic instability. With a frontotemporal dementia, we assess the extent of cognitive dysfunction in these patients. This informs us on how likely the patient can tolerate sedation during this procedure, and if, for instance, if the patient is redirectable or may require a fair amount of TLC to help them get through the procedure. Lastly, we address patient expectations during these preoperative evaluations. So during our preoperative evaluation, we have a dedicated pre-op clinic that we usually have our ALS patients visit prior to the procedure. During this visit, we essentially go through what the patient should expect for their procedure with anesthesia. So we discuss essentially, the patient is brought to the procedure room, positioned to allow for procedural exposure, but also discuss a little bit on how this affects their pulmonary reserve as well. We strive for an incline to kind of help with that. Once the patient is sterilely prepared and draped for the procedure, then anesthesia is started, so we start giving anesthetic agents immediately before the procedure. This allows us to limit the doses of medication that the patients need and also limit the potential long-term effects from those medications. We also discuss the need for supplemental oxygen. Sometimes this can be a point of contention with patients. Historically, patients and their family members have an understanding that supplemental oxygen affects the patient's breathing and that therefore they should never have it. This is the point where we discuss why this is important. We also address with the patients and their family that non-invasive positive pressure ventilation may be needed or may not be available for this procedure if it involves the airway. So ALS patients, as you know, are very motivated to have procedures without sedation. And this is due to their fear of ventilator dependence. This allows us to have a really realistic discussion on the expectations of anesthesia during their procedure. So intraoperatively, what are the goals of anesthetic care? So the overarching goal is that we strive for patient comfort without compromising safety. We know that anesthetic can affect outcomes well beyond the acute postoperative period. So we strive for a situation where we have very little negative effects, and we actually strive for situations where the patient has a better outcome than prior to their procedure. To do this, we provide appropriate ventilation and oxygenation, maintain hemodynamics, provide analgesia, usually using topical local anesthetics, allow for immobility such that the proceduralist can perform the procedure safely. And although amnesia is desired, it is not always guaranteed. So I'm just going to switch gears a little bit and talk about, MAC, so monitored anesthesia care. The American Society of Anesthesiologists defined this not as a continuum of a depth of sedation, but essentially it's a service in which the anesthesiologist is consulted to provide care for a patient undergoing a procedure. So it doesn't necessarily mean it's sedation or how deep the sedation is. It's just a service that the anesthesiologist provides in caring for these patients during a procedure. So when you talk about continuum of depth of sedation, as you can see, there are varying levels of sedation all the way up to general anesthesia. So general anesthesia in this case doesn't equate to intubation necessarily. So in healthy patients, we can often achieve general anesthesia without intubating them, but this is not our goal for ALS patients. For ALS patients, we tend to be more in the minimal to moderate sedation area, and this is why we have the discussions in terms of expectations in the preoperative setting. So these patients will often have, at a minimum, purposeful response to verbal or tactile stimulation. We usually don't require any intervention for the airway. Spontaneous ventilation is adequate, and cardiovascular function is usually maintained. So that's what we strive for, so minimal to moderate sedation, and that is often dictated by the extent of their symptoms preoperatively as well. So as previously discussed, the need for supplemental oxygen can be a point of contention for some patients. And I want to explain the physiology behind the need for supplemental oxygen in these patients specifically. So the traditional thinking is hypoxic drive. It plays a very important role in ventilation and breathing for ALS patients. And that supplying oxygen, so supplemental oxygen in these patients, inhibits this drive in the patient. However, fortunately, unfortunately, however way you look at it, anesthetic agents inhibit it to start. So once you provide anesthesia, the reserve of hypoxic drive goes away. We don't rely on that for ventilation or oxygenating these patients. So that giving oxygen doesn't give any more risk in terms of preventing them from breathing. So to maintain oxygenation, supplemental oxygen is usually required. To provide adequate ventilation, positive pressure may be required unless the procedure involves the airway and therefore limits that. So again, part of the physiology, how do we decide that oxygen in these patients will be needed? So this is just a quick overview of our alveolar gas equation. So as you can see, this just tells us how much oxygen is available in the alveola for use or for absorption by the blood. This is a function of FiO2, atmospheric pressure, partial pressure of water, and PCO2, and then the respiratory quotient, which is approximately 0.8 in most people. And here in Chicago, we're at sea level, and if you factor in room air as part of our FiO2, we resolve the first part of the equation to 150. And then the PCO2, which is basically in ALS patients, tends to be higher, so they're at baseline usually hypocarbic, is when you factor it into this equation, gives you an idea of how much oxygen they should have in the alveola to be available for absorption into the blood. So a close approximation is that the amount of oxygen in the blood, so the partial pressure of oxygen in the blood, compared to that available in the alveola is only a difference of the AA gradient. So as a rule of thumb, as hypoxia worsens, as hypocarbia worsens, hypoxemia worsens. So this is partly why we need supplemental oxygen to help these patients. So I would say in general, when we talk to our patients, we tell them we agree that traditional thinking, yes, says hypoxic drive can be inhibited by oxygen, but under anesthesia, we don't have the luxury of that. And we also know that since it's short-lived, they should be able to return to their baseline very quickly. So looking at the oxyhemoglobin dissociation curve, without having, so our proxy to knowing how much oxygen is in the blood is essentially our oxygen saturation, so our SATs, pulse ox, basically. So your average patient SATs over 90% tell us there's about a partial pressure of oxygen in the blood of 60. As you go towards the steeper part of the curve, small changes in the partial pressure of oxygen translates to marked changes in the saturation. So going back, like I said, in your patient with ALS, who tends to be hypocarbic to start, it already shifts their SATs to a lower level, and also makes it such that any further hypocarbia makes it that they now start to desaturate. So gastrostomy tube. So this is the most common procedure that ALS patients will get. So how do we do this? We have developed essentially a protocol to some extent that most of us are able to access and readily follow to take care of these patients. These ALS patients are at high risk for respiratory depression, as you know, for multiple reasons. They have weak inspiratory muscles and sleep apnea, which lead to hypoventilation and hypocarbia. They're very sensitive to sedatives, and we almost always avoid opiates primarily because of its ventilatory depressive effects. We use short-acting agents in very minimal quantities, and then analgesia is achieved by a multimodal approach that doesn't include opiates. So drugs like ketamine, local anesthesia, acetaminophen, and NSAIDs where feasible. And then positioning again. So the key thing is for the G2 placement, the procedure list usually requires the patient is supine. But in an ALS patient who's supine, you run into trouble with appropriate ventilation, clearing of secretion. So we come to a happy medium where we try to afford them their procedural exposure, but give the patient some incline so that they do a little bit better from a pulmonary standpoint. So ketamine, why am I talking about ketamine? So ketamine is one of the drugs we consider it, if you will, a complete anesthetic. It has the least effect on reducing respiratory drive. So it allows us to maintain respiratory drive and airway patency, provides analgesia, amnesia, and immobility. So essentially it gives us everything we want for our goals of anesthesia. It also is very cardiovascularly stable. So when we have patients that have these labile blood pressure, this also helps us kind of maintain an adequately stable blood pressure. The cons, unfortunately, as you can see, is increasing oral secretions. So ALS patients, as we know, have already issues with sialorrhea. We try to mitigate this effect of sialorrhea by pre-treating them with anticholinergics like glycopyrrolate. Patients often will describe a euphoric feeling, vivid dreams. Some patients have actually described near-death experiences, distorted perceptions. These are some of the conversations we have in the preoperative evaluation so that they have a context that these things are possible. We don't always necessarily have the situation, but it's possible as a possible side effect, but not necessarily unsafe. So like I mentioned, increased secretions we manage with anticholinergics as a pre-medication prior to start of the procedure. When patients have significant bulbar involvement that affects their coughing, swallowing, maintaining a patent airway, we strive for a frequent soft suctioning to help clear that airway. When autonomic dysfunction is appreciated during the procedure, we use short-acting vasopressors and vasodilators to help us control the blood pressures in a short period of time without lingering effects postoperatively. For patients that have frontotemporal dementia, we find that they somewhat have, protection, if you call it, immunity from recall during anesthesia. However, we also find that they may require a fair amount of TLC to get them through the procedure as well. So general anesthesia, key points. Intubation, we achieve intubation with neuromuscular blocking agents, non-depolarizing agents. During the procedure, the patient needs zero to minimal neuromuscular blocking agents, as they already have weak muscles. Reversal of neuromuscular blockade is achieved with sugammadex. So sugammadex is a drug that's been available in Europe for, I would say, over a decade now. Was recently approved by the FDA a couple of years ago, and essentially works by binding the neuromuscular blocking agent and removing it from the neuromuscular junction and allowing for prompt return of muscle function to baseline, essentially. So this allows us to quickly extubate these patients after a procedure, allow them to achieve their baseline neuromuscular function pretty quickly right after. And as you can imagine, this has changed the management of ALS, management of anesthesia in ALS patients quite a bit. We could also use peripheral nerve blocks as an adjunct for pain control, where opiates might be the only other option for pain control. The reasoning is, instead of having the systemic effects of opiates and therefore the voluntary depressive effect of opiates, targeting just the area where the surgery has occurred will limit the effect of the opiates and help achieve pain control. However, this warrants an individualized approach. There's some controversy regarding disease progression with nerve blocks. So this often warrants a discussion with the care team, the surgeon, and the patient. And the goal is to kind of get the patient the best care based on what the issues are at hand. Postoperatively, we almost always use PAP in these patients. This helps us resolve any lingering hypocarbia and allows the patient to approach baseline as quickly as possible. Again, positioning is key. We maintain an upright position in the recovery period as feasibly possible. Opiates, again, are avoided. We use a multimodal approach with non-opiate agents for analgesia. And blood pressure is managed cautiously at this time as the patient approaches baseline as well. So in summary, the preoperative evaluation allows us to visit with the patient and address the many symptoms of ALS that present significant challenges to anesthesia. Also addressing patient expectations of what to anticipate during the procedure with anesthesia. Supplemental oxygen is often required, and we know that anesthesia with moderate sedation, minimal sedation, so monitored anesthesia care, or general endotracheal tube anesthesia is safe even in patients with advanced ALS. That's it. Thank you so much.